cloud. So be aware this is going to be recorded. And if you see me distracted, I'm letting people into the room a little bit. So if you see me kind of looking off to the side, again, for anybody who's just joining us, this is going to be a recorded session. The overview is going to be a quick discussion between Dr. Troisi and I, and then after that, we'll open it up to questions from the guests. Okay. And if you're ready to go, doctor, I think I'm about ready.
Ready.
Okay. So again, my name is Javier. I'm part of the library services at the Houston Community College. I am based out of the West Houston Institute. It's located next to the Alief Hayes College as well. This is being presented by the libraries in conjunction with student services. Dr. Troisi is here today to give us some information, even though we may feel as much as we want to believe that everything is calming down with the virus, and it is my understanding it's getting better. There's still a lot of things that we need to be aware of and a lot of questions that people have. And so the best person that we think is top tier here is Dr. Troisi. I'm going to go over her introduction here. Cathy Troisi, PhD, is an associate professor in the divisions of Management Policy and Community Health and Epidemiology at the University of Texas Health School of Public Health and coordinator for the Leadership Theory and Practice Certificate. Having previously served as assistant director at the Houston Health Department, she teaches courses in public health and leadership with research interests in infectious disease epidemiology. She holds a BA in chemistry from the University of Rochester, an MS in biochemistry from Michigan State University, and a PhD in epidemiological sciences from the University of Michigan. She completed the National Public Health Leadership Training in February 2011 and received the UT School of Public Health Community Service Award in 2013 and 2019, and the Excellence in Teaching Award in 2017. Dr. Troisi received the American Public Health Association Advocacy Award in 2015 and was elected to the APHA Executive Board in 2017. She is the recipient of the 2018 Association of School Programs in Public Health Academic Public Health Practice Excellence Award. Oh, I'm sorry, repeated that. She has had 20 op-eds published in Texas newspapers and given over 450 media interviews on COVID-19. So this is gonna be 451 today. We really appreciate you coming today. I mean, with your extensive bio and your expertise in this, I could not imagine a better expert to present these questions with. So again, thank you so much for coming in. I'm going to start it off with one of the most, I don't want to say generic questions, but a common question that I'm seeing around is wearing a mask still a good idea?
So like, I guess everything about this pandemic, that's, it's not a yes or no answer. It is true that the number of cases are coming down, but we're still at a fairly high level. And what you have to do is figure out what your risk is. If you are unvaccinated, yes, you should be wearing an N95. If somebody in your household is unvaccinated, if you're immunocompromised, if you live with somebody who's immunocompromised or elderly, then you want to protect those people by wearing a mask. And you may want to wear it in situations where there's a higher risk of transmission. For example, indoor settings that are crowded with poor ventilation, places like I sing in a chorus and we all wear masks. Singing is a dangerous activity when it comes to spreading respiratory viruses. So we will continue to wear masks for a while. Basically, you have to weigh the benefits of protecting yourself versus what your risk is in a given situation.
Did not know we had singing added onto your bio too. I'm going to make sure that's in there for the next time. So along with this mask, I might like you said, it is really a risk assessment per person, right? So for instance, myself, I consider the risk assessment when I, for instance, come to work. I work in the library. There's a lot of people coming around. Mm-hmm. I see a lot of people with fabric masks, N95, surgical masks. What kind of masks do you recommend? Because I am hearing some people say, anything is better than nothing. And then I also hear on the opposite end, fabric masks really aren't helpful. So how would you kind of advise us on that?
Yeah, and thanks for pointing that out because I didn't tell you what I'm doing. I'm besides in my choir situation. I wear a mask when I go outside. I'm in my office right now. I'm the only one here. I'm not wearing a mask, but I have one around my neck ready to put on when I go out in the hallway. Yeah, I mean, wearing a mask, any mask is better than not wearing a mask, but we have come to realize that the cloth masks really don't work that well. And because with Omicron, the variant that's spreading right now is so infectious, the recommendations are now to wear N95 mask or a KN94 mask from Korea. The problem with some of the other masks that look like they're filtering is that there isn't good regulatory oversight of the production. So you might be getting one that isn't working so well. And you can look online. I forget if it was the New York Times or the Washington Post had a good article about some of the masks you can find on Amazon or other places that we know are good, have a seal of approval. The KN94, so I just bought some of these. I had been using an N95. The KN94s I had read are easier to breathe through. And I gotta say, I think that's the case. I used it for the first time at my chorus rehearsal, and it did seem to be easier to sing. The other thing is, because, and this drives me bananas, is people who wear their mask under their nose. Wearing a mask under your nose is like not wearing a mask at all. If you're not going to wear a mask, don't pretend you are by putting it over your mouth. That virus comes in and out of your mouth, of your nose, and it's just not doing any good. The other thing you want to look for in a mask, whatever kind it is a good fit. So besides wearing it properly, you want it to fit tightly around the nose, and that's where those wire strips are useful. And you can buy them very cheaply on Amazon and attach them to masks that don't have them so that you get a tighter fit. And then you want it to fit here as well. And this is one of the problems with the surgical masks, is they often don't fit, there's often gaps there. You can help eliminate that by twisting the, I can demonstrate, you can twist it like this around your ear, and that gives you a little tighter fit. So those are some of the things to look for.
So, and I'm going to ask this for personal reasons. I have a beard. And of course, wearing these masks, that's an extra complication. And I know I've been told, well, you should just shave it off, but I'm not there yet. Recommendations for people with facial hair, recommendations for people. So really focusing on that tight fit sounds like the best benefit for that. Is that correct?
Yeah. And I think, it's sort of expensive to try out different masks unless you can buy them one at a time. But they do vary in size, a little bit. Some are, we all have different size faces. And with the beard, you probably need a larger mask to encompass it. So, you might try some different ones.
Another really good question, and I know we're hitting a lot of, personal things. What can we do to keep ourselves safe? Is the at-home testing efficacy? How effective, how trustworthy? Because you hear some reports saying, oh, you know what, that's the best way before you go to work or before you go visit your family, take an at-home test. At the same time, which is, I think, the reason that we have you here today, is there's information going about saying, oh, well, they're not really the most accurate tests. You can't really depend on them. I don't want to say misinformation, but that complicated message. How can we kind of guide ourselves to make sure we're doing right?
Again, like everything with this pandemic, there are nuances. So there are two kinds of tests out there. The PCR that we had at first, which is very sensitive. It will, if you have any level of virus, it will find it. The rapid, but the problem is that it takes a couple of days. And so all it tells you is that 2 days ago when you took the test, you weren't infected. It doesn't tell you anything about, today when you get the result. And you can't, so it's not rapid. The rapid tests are good at determining whether you're infectious. They won't detect a lower level of virus, but that's okay, because you're much less likely to be infectious with this lower load. Now, the other thing about these rapid tests is that they work best if you have symptoms. But if you're using them, you feel fine, but you want to know if you're infected before you go visit grandma, it may not work as well, but it's better than nothing. And, just know that if grandma were to get infected and it would be a horrible situation, maybe you shouldn't rely on a rapid test. But for everyday uses, it's fine.
So I want to hit on a term that you use, infectious, and I've seen that written out in certain news reports, and there is a difference between infectious and infected. Is that correct?
Yeah, so when I say infectious, I mean, can you transmit that infection to somebody else? Make somebody else sick by expelling virus through the air, through your nose, or coughing, and they breathe it in and get infected. So infected is if you actually have the virus, in your body. And, with this virus, it's, we think about 4 out of 10 people won't even have any symptoms. The problem, therefore, is that they can be spreading it, the infection, without even knowing that they are, because they don't have any symptoms, or they have mild symptoms because of the weather changes like we were talking about, or allergies, which are always a problem in Houston.
So, and I like how you stated, with the infectious, infected, with a lot of stuff happening, with the new policies, being presented by the CDC in regards to 5 days of quarantine versus the 7, that was the 10. So the more information we're getting, I understand, is we're learning the time period that we are the most, as you said, infectious, and how we can kind of prevent it from spreading. Can you kind of give us some clarification? Like, I know it's very confusing, and I've heard again, so many different things. Would love some clarification on that.
Yeah, and again, this is something that we're learning about the virus. I mean, the virus, we've only known about it for a little more than 2 years, and we have learned a lot during that time. We're still a lot to learn, but as we learn more about the virus, our guidelines are updated. So with this virus, and one of the reasons that it spreads so easily is, again, you may not have any symptoms at all, but even if you are going to get sick, you are infectious. You can transmit that infection to somebody else before you have symptoms. That makes a virus very easy to spread, because you're going around your daily business and, seeing people. And that's why we wear masks, even when we're not sick, or when we don't have symptoms anyways. So we know that the average length of time after you have symptoms, and I'll get back to this because this is a problem if you never have symptoms, but let's say that you do. The average length of time is about 5 days. 85% of people, that is most people, after 5 days will not be able to infect somebody else. Now, that leaves 15% of people who can. The CDC revised its guidelines partially in response to the fact that making people quarantine or isolate. So there's a difference. Quarantine is if you've been exposed, isolate is if you're actually sick. Making them not go to their jobs for 10 days was playing havoc in many industries. And so the decision was made that because most people after 5 days are not shedding virus, that it would be okay to go back to work with a mask. And that often is left off when we talk about these guidelines. So, and I was going to say, so that's if you have symptoms. Now, if you take a test just for whatever reason and you find out that you're infected, you have no idea when that infection started. I mean, if you don't have symptoms. So therefore, the recommendation is just for the sake of, you got to have some time that you start. It's the day that you took the test. All right, I think you're muted, Javier. Or at least I'm not hearing you. I can read your lips.
There we go.
There, thank you.
Okay. Let's see here. What I was going to say, so I know we talked about, infection, the time frame of infection, and a lot of people are starting to see new variants popping up. I know in the news right now, they're talking about a variant of the Omicron. I know it's super early and I don't want to tie you down to anything, but of the information that you have with you, how would you, basically, will there be another surge? I think is the big question. Is this something that we need to be concerned about?
So, yeah, my crystal ball is not infallible, but it is certainly something we are concerned about because of the nature of this virus, there are often mistakes made, what we call mutations, in the genetic material, in the RNA, every time more virus is made. So the more people that are infected, the more chances there are for a variant to arise that has these mutations that can make it more infectious. That's what we saw with Omicron and with Delta. And we have not seen yet, thank goodness, a variant that it makes more people sick, is more virulent. So whether there will be another surge, it's very hard to predict. However, we haven't done a fantastic job of vaccinating people in the United States, but the rest of the world, it's about 40%. And so there's a lot of susceptible people out there who can get infected. The virus can make more of itself, and the possibility for variants to arise. Now, the variant of Omicron, which is a variant itself, a subvariant is what we're calling it. It's called BA2. And there are, again, new, it is in, I think, 57 countries, a lot of countries around the world. We're seeing it in the United States. The latest data show about 4% of people who are infected have this BA2. What we're looking at is, are we going to see a rapid increase in cases? It does appear to be more transmissible even than Omicron, about 30% more transmissible. What we don't know yet is whether it causes more severe disease. There was an animal study, so animals are not humans, but there was an animal study that showed that, yeah, it does seem to cause more severe disease. But if you look at humans who have been infected with it, there doesn't seem to be any difference in the clinical severity compared to the Omicron, the first Omicron, which is BA1. So again, we're waiting to see, but the possibility of another surge is always out there.
So you touched on a really good topic there during your conversation, and it was the vaccines, right? We know our vaccines are working. We're confident in the vaccination process at this point. And unfortunately, we don't have the highest numbers, I think, that a lot of people would like to see for safety. But what about a fourth booster? So right now we've had, your original shot, your second shot, and then a third booster when Omicron became, an issue. Now, is a fourth booster something that's being talked about? Is that something that we need to be concerned about? And then along with that, I've heard, and I'm not as well read in this topic, pan coronavirus vaccine, a vaccine that affects just any variant of the COVID vaccine.
So to answer about the whether a fourth booster will be necessary, I think the jury's still out. There are certainly some groups, those who are probably those over 85 years of age, those who are immunocompromised, where they just don't respond as well to a vaccine, that a fourth booster is recommended. The question is, for the rest of us, is a fourth booster needed, or a fourth dose rather, be a second booster, and if so, when? And the studies that have been done, you may have read that just recently there were some studies showing that as soon as 4 months after you received a booster, so your third dose, your antibody levels start to decline. However, our immune systems have two main arms, and one of them we measure the antibodies, and that's pretty easy to do. You draw some blood and you can measure the antibodies. The other arm of the immune system, which is particularly important with viral infections, is called cellular immunity. And it's harder to measure. I mean, it can be done. It's just not as easy as measuring antibodies. So a lot of the studies have been with antibodies. If you look at the cellular immunity response, that seems to hold up pretty well, like it does with other viruses. So again, the jury's just still out. Will we need a booster every year like we do with flu? I don't know. It's also going to depend on if a new variant that the vaccine does not protect you against arises, then we will need another dose. In terms of a coronavirus vaccine, that would be wonderful. This would be a vaccine that would protect you against any coronavirus, but there are a lot of technical difficulties to developing this. And we have been talking about a pan-flu vaccine for, I don't know, decades maybe, and it hasn't been developed yet because there are a lot of, again, technical issues. So, certainly people are working on it. It would be wonderful, but I wouldn't hold my breath for it being ready next year.
So I do have a question in the chat, and before I ask the question, I do want to emphasize Dr. Troisi is here as a guest, and she's giving wonderful information. But any decisions that you make for yourself or for those around you, those are decisions that you should speak to your medical provider before making. Is that correct, Dr. Troisi?
Absolutely.
So,
and I just want to say I'm not an MD, so I
right.
am not going to give medical advice because I don't want to be sued.
Yeah, right there with you. But I wanted to preface that before I ask this next question. The question was, what about a fourth booster for those who are elderly compromised? I think you touched on that. And then the second part of that was, and how long after the third should you get that fourth booster if you are elderly and compromised?
That is a good question. And honestly, I don't remember the answer to it. And it may depend on your particular situation. You don't want to get it too soon. You can, we think more is better, but I mean, in general, we think more is better about most everything, right? More chocolate is better than less chocolate. But that may not be the case with boosters. So you really have to talk to your healthcare provider for your specific situation.
A couple more questions. So, there's a lot of news and information out there. There's a lot of stuff coming out, both in science journals, if you follow science journals and magazines, and even in mainstream and even tabloids at this point. So the confusion comes is, where can I get the best and most accurate information so that I'm making those good decisions for myself or for those people that I care about? What resources can I go to that would provide that information as unbiased as possible?
Right. CDC is always a good source of information. Now, the problem with CDC is that they have to be very conservative in what they're putting out. It has to go through, the bureaucracy is incredible. And so it may not be as timely as you might want to see. Other good sources are your local health department. Here in Houston, we have two of them, Harris County. Well, we have three, Harris County, Fort Bend, and then Houston. There's also a state health department, Texas Department of State Health Services, DSHS, we call it DSHS. Those are good sources, but also trusted media sources like the New York Times or the Washington Post do a really good job of putting scientific information into sort of everyday language. So those would be the recommendations I have.
Oh, good. And I asked that question specifically because, as it says in your bio, 450 media interviews, 20 op-eds. If there's anybody who knows the best place to get information, it would definitely be you. So this, as we're kind of coming down from the conversation, and then we're going to open up to public questions. Before we get there, though, what are the predictions, or what are your, I know, like you said, your crystal ball, right? And I don't want to tie you down to anything, but the virus itself, we're hearing pandemic. changing. What I'm hearing, at least, is the term is changing to endemic, and whether or not, what exactly does that mean? I think we're all familiar at this point by what pandemic is, but maybe not so familiar with the difference between a pandemic and an endemic.
Yeah, so just to remind you all, an epidemic is when we see an increase in the number of cases above a certain threshold, which depends on what disease you're talking about. For example, if we were to see one case of smallpox has been eradicated. It's the only virus we have eradicated from the world. If we were to see one case, that would be an epidemic. One case of the common cold is not an epidemic. You'd have to be seeing, I don't know, millions of cases. So, but with this virus, it was a new virus. So again, really one case started the epidemic once we saw it could be transmitted from person to person. Endemic means that a disease is around, a pathogen, either a virus, a bacteria, a fungi. They're around, usually at a lower level, and often it refers to diseases that are confined to certain geographic areas. Now, this will not be. SARS-CoV-2 is going to be around the world. However, when we see endemic used nowadays, it's sort of synonymous with not such a problem. It's like, the common cold. But we have endemic diseases like TB and malaria, not in the United States, but in other parts of the world, that still kill a lot of people. So endemic is not synonymous with not a problem. You may also have seen it compared, the SARS-CoV-2 compared to flu. And, I used to study flu. I don't anymore. But we talk about flu, first of all, there's confusion about other illnesses and illnesses caused by the influenza virus. You can be darn sick with, and even if you don't die and aren't hospitalized, you can be darn sick with influenza. It is not just a bad cold. We also see a number of deaths, and it depends on the year. This year happens to be a very mild year again. And we can talk about why if you want. But we do have years that are very bad for influenza. And in an average year, 59,000 people in the United States die of influenza. In a bad year, more. And it's not just elderly people. It is elderly people and those with comorbid conditions, but it's also young folks. And in 2019, there were 199 pediatric deaths, which is just heartbreaking because they didn't have to happen. So comparing SARS-CoV-2 to what we experience with flu, again, doesn't mean mild. We have decided to accept the number of deaths that we get from flu. Our vaccination rates are not good, even among healthcare workers, interestingly. And so people get sick. But we've decided to accept that. We don't talk about the number of deaths, except in public health, we talk about it. But and I think we are, as a society, are going to decide we're going to live with a certain number of deaths from SARS-CoV-2, and we'll just call it the end of the pandemic, even if the virus is still around.
So as I look through your bio, you have a lot of background in public health and the public health community. Something that we're seeing a lot of nowadays is kind of a shift away of taking information and advice from public health professionals or professionals in any specific field right now, and going with this kind of what they present as really good questions versus information that we do know. Have you seen that yourself? Is that something that you've struggled with? I mean, I'm teeing up the question, but and I have no doubt, but what kind of struggles have you seen, and what do you think can kind of help that? What way can we kind of go around that very significant problem? And if you can
Well,
solve
yeah,
world
I don't
hunger
think it comes
today.
as a surprise to anybody that, there's a lot of misinformation out there, and a lot of um, lack of trust in public health. Part of that comes from the fact that public health is often a governmental um, function. Health departments, whether they're local or state or national, CDC, are run by governments, and we have a lot of distrust of government in the United States. It's going to be very difficult to get that trust back, unfortunately. And if I had the answer to that, I'd probably be winning a Nobel Prize. I don't know. I mean, it's certainly talked about a lot, but some of it, and then there's the problem of misinformation through social media. We've got our armchair epidemiologists who, talk about things they have no idea about, politicians, movie stars, et cetera, who, talk about that. CDC's made a number of missteps, unfortunately, which hasn't helped the situation. Yeah, it's, if you had asked me 2 years and 3 months ago, I guess, before the first cases, what would happen if we had a pandemic? And, when I was in graduate school many, many years ago, we knew there'd be another pandemic after 1918. And we did see one in 2009 with a flu virus that turned out, luckily, to be much milder than we were concerned about. But if you had asked me what would happen, I would say the country would come together like after 9/11. And boy, was my crystal ball wrong on that one. And, I mean, I don't mean to get into politics, but, the country's very divided. And how you talk about the pandemic is a function of your political persuasion, and it's an identifier. If you are of a certain party, then you have to believe this about the pandemic, and vice versa. So yeah, it's and if we have, and we will have another pandemic, I hate to tell you, but it will happen. If we're lucky, it won't be for another 100 years, and none of us will probably be around. But there's no guarantee it won't happen tomorrow, that there aren't some cases, someplace right now that will blow up like this did. And I think we will be in a worse position to combat the pandemic because of the spread of misinformation, because of taking away of public health authority, because of distrust of public health messaging.
So I'm not going to ask you to solve world hunger today either. I know
Oh, good.
that was a big question, and but thank you for your insight into that. So at this point, I'm done with anything that I wanted to kind of present and ask, and so I want to open up the chat to anybody else who's here. You're welcome to type in the questions. Let's see. Now, I don't think we can answer this question, but I will say for the chat for the person who asked about the 4th booster shot, getting a doctor is difficult was the reason for asking about the booster.
Yeah.
So I can understand. I think everybody can kind of understand that, and we do wish you the best.
Yeah.
Looks like we have a question. I think we touched on it. Is, do you have any recommended information sources to follow? So I think previously it said the CDC, Washington Post, and New York Times that you found was giving good digestible information. Is there any other sources
Yeah,
that you
and
recommend?
I would add your local health departments, because they can tell you what's happening in your community.
Okay.
So the Houston or Harris County Health Departments, Fort Bend Health Department, the Texas Department of State Health Services.
And even though this is such a global issue, when you say the community, it's so different community to community, right? And the information that you're receiving from smaller communities, say you have one small rural community and there's nobody there who has, luckily has caught in the virus. So their information and that mindset might be different, say from a metropolitan area such as Houston. Is that correct?
Right. And like we saw in the first days of the pandemic, it's urban areas that are going to have the first big clusters of disease because we live close to each other. If you live in rural Texas and your nearest neighbor is 10 miles away and you go to the grocery store once a month, or whatever, you're just not likely to be exposed. The other, I was going to say something else. One of the reasons that we have these different responses in the United States, unlike other countries, is that in the Constitution, in the US Constitution, public health is a state's right, it's issue. It is not given to the federal government, and any power that isn't given to the federal government is by default belongs to the states. That's why we've seen such different responses, for example, in Texas versus New York, to responding to the pandemic. And that's always going to be an issue because we are not isolated. Maybe if you're in that rural, 10 miles from your nearest neighbor, but how many flights come in and out of Houston every day, global as well as national. And so anything that's spreading is going to come to us. We can't isolate ourselves. We're a global economy.
Yeah. Do I have any other questions from the chat? Please feel free to ask. This is, wonderful. You have such a professional here today, and definitely want to open up if you have any questions. You can put them in the chat. If you want to make it anonymous, you can direct message me and I'll ask the question for you. And that's perfectly fine as well. So I'm going to allow y'all to think about what questions, if you have any. And while that's happening, Dr. Troisi, is there anything that you kind of wanted to speak to or to say on your end as kind of an ending for the presentation?
Well, I think like we started out, we are hopeful. We've seen the number of cases come down dramatically, but we're still seeing deaths, which is what we call a lagging indicator, because you don't usually die right away from the virus. It's usually a couple of weeks later. The problem with looking at the number of cases is that with at-home testing, not all those cases get reported. And there's been talk that, well, as long as our healthcare system, our hospitals can handle any cases that arise or that need to be hospitalized, if there's enough ICU beds or hospital beds, then we're okay. But as I was saying, I don't think that's the case, because if we have a lot of infection, even if people aren't getting hospitalized and dying, which is great, but the possibility of variants arising increases. And there again, no guarantees. That's sort of my buzzword, no guarantees. That the next variant won't cause more severe disease or be even more transmissible, or who knows what. So we really want to get the number of cases down. The best way to do that is through vaccination. And we also, the other thing is, when you talk about getting infected with COVID, especially if you're young, let's face it, your odds of dying are small. The vaccine does protect you, and now most of the cases and hospitalization are not cases. Well, yeah, cases and hospitalizations and deaths are in unvaccinated, but still your odds are small. But we haven't talked about long COVID and what that can mean. And there's just more and more coming out about long-term effects of even a mild COVID infection that, why would you want to risk that?
And I want to apologize to you in the audience. I did think about that question. That is a very good topic, is that long-term effects of COVID. I've heard heart issues. I've heard digestive issues that have lasted. I've heard people who still, after months, have not gotten their taste of sense, or their sense of taste and sense of smell back. Excuse me.
Well, it's been linked to diabetes in children. And also there are changes to your brain, not in everybody, but in some people, that look like Alzheimer's. I mean, to me, that's scary. The virus can infect basically every organ in your body. And that's why we see all these different, sequelae from being infected.
Well, I have a message here from one of our guests saying, I want to say a huge thank you to Dr. Troisi for your message today. So, it's whatever you've presented today has definitely hit home for some people. It has been nothing but informative, and this has been such a wonderful chat. I know this is our second time talking, so I appreciate you every single time you come on. Um, Oh, here's an interesting question. This is a good one. EEOC has now accepted COVID for medical conditions. What are your thoughts in regards to that?
Yeah, one of the things we have not talked about as a community or as public health or medical professionals enough are the effects of long COVID on society. And we have had so many people infected. The percent that develop long COVID, it's a little unclear. It's probably between 1 to 3 out of 10 people infected. As I said, and it's not just those people who were severely ill. Even mild infections can lead to long COVID. And this may have a long-term effect on society. In terms of EEOC, I think the problem is going to be that right now we don't have the definition of long COVID, or what do they call it? COVID, there's another term for it. Vary from study to study. So I think it may, and it's sort of like chronic fatigue syndrome, if you've read about that some people don't think that's real, that the symptoms that you have vary a lot from person to person, and it's hard to measure brain fog, for example, which is seems to be a common one after COVID. So I think that's going to be the problem with EEOC.
Are there any indicators?
COVID long haul. Thank you.
Are there any indicators for the COVID long haul that we can kind of see beforehand, before infection? Again, I've heard here or there, but I don't know how accurate that information is.
Yeah, there was a study out, I don't know, maybe a month ago. For me, and it may be the same for you all, time has no meaning anymore. It's very hard to remember when things happen. That's because every day is the same, right? We don't have any markers about, to put things in time. But there was a study a month or so ago looking at predictors of who was going to get long haul and what maybe some of the reasons for it are. One was, which is going to contradict what I just told you, severity of infection. So you were more likely to have long haul if you did have severe infection. However, what I said before is still true, that's, you don't have to have a severe infection to develop long haul. Another theory, if you have an underlying condition, for example, diabetes, you were more likely to develop long COVID. And one of the theories, there's certain type, another thing that predicts it are certain types of antibodies. They're called autoantibodies, that is antibodies made to your body, which we don't want because antibodies should protect you from an outside invader. You don't want your liver to be attacked with antibodies. But what some of the theories about why people may be developing long haul is development of these autoantibodies, or it may be that the virus can last in your body for a while and then get what we call reactivated. And this is a theory, this has not been proven, but there are parts of your body that the immune response can't get to. The testes in males are one of those protected sites because we don't want antibodies attacking sperm. And so there has been at least one study, maybe more, showing that you can isolate virus from testes of infected men. It could be that there are other spots in your body where the virus can hang out. It also could be that the SARS-CoV virus is reactivating other viruses that there are viruses that we live with and as long as our immune system is doing its job, those viruses are under control. Herpes is an example. But if you get stressed or you're not sleeping enough, you can get a cold sore. The herpes virus wins out over the immune system. It may be that. The other theory for what may be causing some of these long haul symptoms is that there are microclots that are forming and causing issues. If you have read, we know that coronavirus can do this. So that's just some of the information that we're still trying to determine exactly what the story is.
So I have, I think we answered this question earlier, but I think it was a latecomer. It says, since the virus can reactivate, then is the new CDC guidance of 5 days isolation as safe or safe as, that 7 to 10? I think you kind of touched a little bit about that, the differences between the 5, 7, and 10 days. But with this new reactivation discussion, so if the virus is living in our system, and I'm assuming that 5 days is still too soon for it to reactivate, that if we're looking for reactivation, it'd be longer than that. Is that correct?
Yeah, and let me just say, I am not saying nobody knows whether everybody, that the virus hangs out in everybody and can be reactivated. It may be only in some people. The 5 days refers to the fact that 85% of people will not be shedding virus, that is, breathing it out or coughing it out after 5 days. Although some people will do it longer. And that's why even after 5 days, you're supposed to be wearing a mask for another 5 days. There are people who are immunocompromised who have had the virus. You can detect virus for months and months and months, but that's a special situation. Their immune system isn't working and isn't taking care of the virus. So.
Okay, well, I think that's it for the chat, and that's it for me. I think Ms. Dominique is here as well. Ms. Dominique, I do want to say thank you so much for Student Life for hosting both of us. Thank you, Dr. Troisi, for coming in. It's always nice talking to you. And if there's no other questions, I think we're going to be ending 10 minutes early, which I think is okay. I think we did. We got a lot of information in within those 45, 50 minutes. Okay, I think that's going to be it for today. Thank you everyone for coming in. There's going to be a lot more Student Life presentations. Hopefully we can get Dr. Troisi back again at another time, and maybe in a
hopefully you won't need me back.
Hopefully we won't need you. But again, it's always nice having this conversation. And I think I was gonna stop the recording if Miss Dominique is still on here. Let me see here.
I'll go ahead and end it for us. Thank you so much. And thank everyone for coming.
All right. Bye-bye.
Goodbye. Thank you.